Good evening, everyone, and thanks for joining us. Let's go ahead and get started. My name is Alyssa Strackbein, and I'm the Operations Manager for the Appendix Cancer PMP Research Foundation. I want to welcome you to the latest webinar in our 2026 educational series. We are very excited to have Doctors Laura Lambert, Noah Cohen, and Zachary Brown here with us tonight. This esteemed panel of experts will review and discuss the recently released National Comprehensive Cancer Network guidelines for appendiceal cancer, as well as the current Peritoneal Surface Malignancy Consortium guidelines. And before I turn it over to them, just a quick refresher. The Appendix Cancer PMP Research Foundation's core mission is to fund and support research to discover new treatments for appendix cancer with the hope of one day finding a cure for all, and to fund and support educational programs for healthcare professionals and patients, caregivers, and families to keep current with the evolving science and to increase awareness about this rare cancer. All of this work is made possible only by the generosity of our donors, and we are so grateful for your support. A few quick housekeeping items. At the end of the review and discussion, the panel will address a selection of pre-submitted questions from registration and as many live questions that they are able to address as time allows. Please use the Q&A feature at the bottom of your screen to submit questions. We will not be using the chat feature. Lines are muted to reduce background noise. The presentation is being recorded and will be available about an hour after the webinar is over via the Zoom event lobby and through an email. It's also going to be made available on acpmp.org and on our YouTube channel later next week. If you have any questions or topic ideas for our webinar series, please reach out to our Executive Director, Deborah Shelton, at deborahs@acpmp.org. All righty. And now to the main event. One second. Oops. Just trying to make sure we can see everybody. There we go. All right. Okay, and with that, I'm going to introduce our speakers tonight, starting with Dr. Laura Lambert. She's the Professor of Surgery, Vice Chair of Academic Affairs and Surgical Education, and the General Surgery Residency Program Director at NYU Grossman School of Medicine, NYU Langone Health on Long Island. Dr. Lambert earned her medical degree from Harvard. Her general surgery residency was completed at the Dartmouth Hitchcock Medical Center, followed by a 3-year fellowship in surgical oncology at MD Anderson. She has held faculty positions at MD Anderson and Department of Surgery at UMass Memorial Medical Center at the University of Utah, where she was the director of the Peritoneal Malignancy Program at the Huntsman Cancer Institute and the program director for general surgery at the University of Utah. Dr. Lambert's clinical practice focuses on the comprehensive management of peritoneal malignancies. Dr. Lambert is also board certified in hospice and palliative medicine. And of course, we are so grateful that she is the chair of ACPMP's Medical Advisory Board. Next up, we have Dr. Noah Cohen. He is the Section Chief of Complex GI Surgical Oncology and Associate Professor of Surgery in the Division of Hepatobiliary and Pancreatic Surgery at NYU Grossman School of Medicine. Dr. Cohen earned his medical degree at SUNY Upstate Medical University and completed his general surgery residency at NYU Grossman School of Medicine, as well as a postdoctoral research fellowship and a complex general surgical oncology fellowship at Memorial Sloan Kettering. Dr. Cohen's clinical focus is gastric cancer, retroperitoneal sarcomas, and peritoneal surface malignancies. He also has expertise in robotic-assisted procedures and in performing CRS HIPAC. And then last but not least, we have Dr. Zachary Brown. He is an assistant professor of surgery within the Division of Surgical Oncology at NYU Langone Health. Dr. Brown has a special interest in treating patients with advanced or metastatic cancers originating from the appendix, colon, small intestine, stomach, and peritoneal surface. As a board-certified surgical oncologist, he is an expert in treating patients with CRS HIPAC. Prior to joining NYU, Dr. Brown completed his general surgery residency at Rutgers Robert Wood Johnson Medical School, as well as fellowships in tumor immunology and surgical oncology at the National Cancer Institute, National Institutes of Health, and a fellowship in complex general surgical oncology at The Ohio State University and the James Cancer Hospital, where he received specialized training in treating patients with advanced and metastatic cancers. Thank you all again for being here. We are so grateful and excited to have you here and for this discussion. And with that, I will hand it over to Dr. Lambert.
Great. Thank you, Alyssa, and thank you so much to the ACPMP Research Foundation for hosting this event tonight and for allowing us to join you again with my colleagues, Dr. Brown and Dr. Cohen. We're really excited to be here to talk about the recent guidelines, anything and everything about guidelines for cancer, but specifically, obviously, about appendiceal cancer. I'll just let you know, Dr. Cohen is actually going to have to jump off a little bit early, so that's why we wanted to get going as quickly as possible. But it's great to see so many of you joining us tonight. I actually see a number of names on the list, people that I know, so it's great to see you and glad that you could join us. So we're gonna kind of dive right in. I know this is a relevant and timely topic. Dr. Levine from Wake Forest recently published a editorial in the Annals of Surgical Oncology addressing the guidelines that now exist for appendiceal cancer, which I have to tell you is truly remarkable because for a very long time until recently, there really hasn't been anything like this. So we're excited to talk about it. I think it's a testimony to the amount of research that's being done in appendix cancer, the amount of attention that's being given to this rare cancer, and the progress that we've made over a relatively short period of time. So I'm actually going to start with a question for Dr. Cohen, and we're hoping this is going to become a little bit of a discussion and you guys can sort of listen in. But I was going to ask Dr. Cohen if he could just speak briefly about, just in general, what are cancer guidelines and how do physicians use them in general?
Sure. So you can hear me okay? Just want to make sure.
That's good.
So cancer guidelines are evidence-based recommendations developed by expert groups that review the latest research on how to diagnose and treat specific cancers. And they bring together data from clinical trials, real-world experience, sometimes even expert opinion, to outline what is considered the safest and most effective care. And these recommendations can be based on high quality data like randomized trials if they exist, if they're available. Sometimes they're based on other data that may not reach quite such a high level, like observational studies, or as I said, expert opinion. And physicians use these guidelines really as a roadmap when making treatment decisions for patients. And they help ensure patients receive high quality standardized care wherever you may seek care, while still also allowing doctors to tailor recommendations based on an individual's patient condition, their preferences, and of course, their overall health. So sort of just gives us a little bit of a baseline standardized starting point where doctors can at least begin a conversation with the patient.
Yeah. And, as you guys know, both of you and everybody on this call knows appendix cancers and tumors are incredibly rare. So I'm sure a number of people on this call have been in a position where they've gone to see somebody and the person has said, wow, either I've never seen this or I saw one of these when I was a resident, and they're not really sure what to do, right? And so Dr. Brown, in your experience, how do you think these guidelines will help people in that situation? What can we do to encourage the use of them so that people will be able to get to the care that they need to get to?
Yeah, that's a great question. I think Noah used a very important term that I like to use, is that they're a roadmap, and it kind of gives a generalized guide on what to do in different pathways that exist. If you open up many of the guidelines, you see a lot of branching points where you see if you in this situation, you can consider this. If you're in a different situation, you consider that. It depends. It's a little different when we look now at the former Chicago consensus, now known as the Yale consensus guidelines, and the NCCN guidelines. A lot of it is similar, but there's a little bit of differences in there. And so I think to just kind of, use your best judgment in using these as a roadmap to approach patients with sometimes often difficult problems. But what I like to think is these are guidelines and roadmaps, but before you treat the cancer, you have to first treat the patient. And you have to know the person you're dealing with. And recommendations are one thing, but can that person actually tolerate, or should they get what's actually recommended? And I think that's really where it comes in to be a good clinician and be able to treat the patient and not just the disease.
Agreed. Yeah. And so, there are, as you mentioned, you alluded to, there are already a number of guidelines that include appendix cancer. Probably the most well-known is the National Cancer Comprehensive Network, or the NCCN, as you talked about. And that's probably the most well-known in the world. The next most well-known and the earliest that appeared in the US would be what we're now calling the Peritoneal Surface Malignancy Consortium Guidelines, or formerly known as the Chicago Guidelines, and some informally known as the Yale Consensus Guidelines. And that was really driven large by the efforts of Dr. Chiraga, who was first at the University of Chicago and now is at Yale. And those are just fantastic. These were really, truly the first guidelines that came out specifically with guidelines for appendix cancer. The other group that has been very much involved in this is the Peritoneal Surface Oncology International Group, or SOGI. And they have published guidelines for many years, and probably the most well-known in peritoneal disease-specific guidelines in Europe. And also, the American Society of Colorectal Surgeons actually have published guidelines on the management of appendiceal cancers. They started their first version came out in 2019, and they just recently updated them in 2025. And so, Dr. Brown, can you just speak briefly about the different methods of how these guidelines are created?
Yeah, and I think Noah touched based on this before. It's to use the best data and the best evidence that you have. The NCCN goes through a pretty extensive process where NCCN designated centers then elect a representative from the institution, who then, for each individual disease site, whether it's appendix, it's colon, gastric cancer, they have a representative who then goes to meetings to discuss current literature updates, different standard of care that people are now implementing, and then to really have committee meetings, and they're supposed to talk with the people at their institution who are truly disease site experts to get a consensus on what they should put in these guidelines. So that's how NCCN generally runs to do it. I know I've heard Dr. Chiraga talk about the development of the peritoneal surface malignancy guidelines here in the United States, and it really sounded like a truly Herculean effort to put these together, where he used a big group of residents, medical students even, and then collaborated a lot with peritoneal experts across the United States, and they went through different rounds of testing, of asking questions and getting answers, and going back to the data, and really doing what's called like a Delphi method, and going through and looking through the best evidence in the literature to come up with standard guidelines for us to help use to treat patients.
Yeah. Yeah, and I think one of the really unique things about the Peritoneal Surface Malignancy Consortium guidelines, or we'll call them the Yale guidelines now, is that they also involved patients and patient advocates in that process. So I think that's something that is unique to that process. I know you guys are both familiar with both. Any thoughts or like different what strikes you? Is there any major differences between the two guidelines, NCCN versus the Yale consensus guidelines, or are they pretty similar? What are your thoughts about that?
I can at least start with this. I mean, they're pretty similar. There's actually a lot of overlap. There are a couple areas where NCCN does a much deeper dive into chemotherapy, into systemic therapies, and also for biomarker testing. So when we're talking about doing mutation testing, like BRAF or KRAS, if those are familiar, or HER2, And NCCN is a little bit more comprehensive than the Yale guidelines. These are not really even mentioned in Chicago because the Chicago guidelines were written well before a lot of the targeted drugs that we have now, and so they weren't even thought of as important things to look at that time. But that's one. I'd say major difference is not just talking about the surgery side, but really on the chemotherapy and biomarker side. The other thing that's possibly a little bit different is that for patients specifically with low-grade appendiceal mucinous neoplasms or lamins, that for localized disease, actually surveillance of localized disease is an option for NCCN. It's a little bit different than Yale and Chicago, where cytoreduction and HIPEC is recommended across the board, whether it's localized or sort of more diffuse acellular mucin.
Great.
And to piggyback right off of that, I think one of the important differences is if you look at the authorship of who's heavily involved in who made these guidelines, the NCCN guidelines are very heavily weighted in medical oncology. Is that a vast majority of the authors on those guidelines are medical oncologists, and so they really delve deep, like Dr. Cohen said, into the medical treatment on the different chemotherapy regimens. I mean, there's pages of them of different options you can use with targeted therapies, and then I feel like the Yale consensus is surgeon led. So the one thing that I really like, and I refer to patients and talking about them with their disease, is especially if you look in the metachronous disease, so people who've had their appendix out and then develop peritoneal disease at a later time, they really help stratify who's high risk. Who are these high risk people? When was your recurrence? What's your tumor markers showing? Where is the disease? What is the characteristics of your primary tumor? Did you have lymph nodes or not? And so it really kind of helps break down the nitty gritty of should you do this or should you not? And I think that can be very helpful for surgeons, but also for patients who are looking at it.
Yeah. I think the other thing about that I really like about the Yale consensus guidelines is then the comprehensive review that they do. They really did a system. They identified two or three key questions about each disease. And then they did drilled down really hard and did like a systematic review of the literature. That was really well done. And so when you go and you read those consensus guidelines, in addition to the roadmap that they provide, there's also a really nice review of, again, a couple of specific questions related to that topic that they decided to go deeper in. And they also, the other thing that I like about those guidelines is that they include social determinants of health, which I don't think is something that's in the NCCN guidelines. I will also add that I think the NCCN guidelines are still a work in progress for appendix because before it was just lumped in with colon. And we all know that the appendix is not the colon, right? Like everybody knows that here. So great. Well,
I mean,
yeah,
sorry, I didn't mean
go
to
ahead. Go
cut
ahead.
you off with that. Like, just piggybacking off of that, if you pull up NCCN guidelines from for other disease sites, at the very end, there's a very long discussion generally. And
Yeah,
the appendix right now, it still says under development.
under
So
development.
it's still a work in progress.
It is, yeah, very much so. It's coming. And I agree with you, like in looking at the authors on that, it is mostly very heavily medical oncology. But as Dr. Brown said, the idea or the concept is that there's somebody at these designated cancer institutes where there's a lead for that section, and then they're supposed to talk to the content experts at their institution and get their input. So they may not show up on the author list, but hopefully that's where they're getting their input from, so that they're still using the collective wisdom of the community that takes care of these patients the most. So, well, great. Dr. Cohen, I guess maybe just some logistical questions here. Can anybody access the NCCN guidelines? And if so, what guidance would you give to patients, their families, their primary care doctors about using them?
Yeah, absolutely. So anybody can. The NCCN guidelines are available. It's nccn.org. You just have to make a profile, make like a username and a password. So you do have to log in every time. And then each cancer for which there is a guideline, so not every cancer has a guideline, but many do, and finally Appendix does. You can click on that and then you'll be able to see what the guide, it's like PDF files that show up. I think it's very helpful for patients to certainly read. I mean, it's not written, it's written for physicians, so it uses medical jargon. But just for a patient to understand sort of why a doctor they might be seeing is giving a recommendation. Well, to go back to the NCC guidelines, because they are so commonly cited and used in clinical practice by most doctors. And again, most doctors don't see patients who have appendix cancer. And so that's probably going to be a resource that if the physician that you might be seeing doesn't know that they exist, it might be a good thing even for a patient to say, hey, can you look at the NCCN guidelines? They may not even know that there's an appendix section now because it is so new. And so that's very helpful. It's also helpful because possibly in the past, and depending on where some patients seek care, the idea of cytoreductive surgery, the idea of HIPAC is not even, in as part of the conversation because it hadn't made it to a guideline, let's say. And here it sort of gives front and center, in the guidelines there, a very clear recommendation for when surgery should be considered, and not just stay on chemotherapy and never see a surgeon. And so again, some doctors who may not see too many patients with appendix cancer in their career, is very helpful for them, as well as for the patients and their families to review these NCCN guidelines to see actually what's in them. And so nccn.org, just create a username and password and you can log in and see the guidelines.
And it's free, like you said, and you just have to set up an account. This is what it looks like. You'd click on appendiceal neoplasms and cancer. It is a PDF document, basically, and you can just scroll down. You can see all the people that contributed to creating the guidelines. These are the representatives at the different institutions. It tells you like what version it is. This is version 1, 2026. So really kind of hot off the press. And then as we were talking about earlier, you'll see this is kind of just a quick snapshot to depending on where the person's starting coming into these diagrams, you find out. So example, at the lower part of the sheet here, confirmed appendiceal neoplasm or cancer, appropriate for resection, or an incidental finding already resected. It tells you what workup you should do, tumor markers, imaging, blood tests, colonoscopy, talking about fertility if it's a young patient. And then you kind of just keep following this down, staying in your lane. The pathology was reviewed depending on what type of tumor you have, from a low-grade appendiceal mucinous neoplasm to an adenocarcinoma, goblet cell cancer, undifferentiated, whether it's localized to the appendix only, whether it's in the peritoneum, the peritoneal cavity, whether it's extraperitoneal, and then you just kind of keep following these lanes down. Lamin and Hammond, appendiceal adenocarcinoma, goblet cell adenocarcinoma, localized, the surgery that you should have, or the chemotherapy that, what you should go on. And they do recommend certain lines of chemotherapy. So you just kind of keep following these down, and then eventually you will get to like some guidelines about the principles of the imaging, the principles of pathology and the molecular review, what we should be looking for under the microscope. They'll talk about the principles of surgery and intraperitoneal chemotherapy, the principles of palliative systemic therapy or chemotherapy. And it'll go through, so it has a lot of information for pretty much anybody and everybody. And then at the very bottom, or after all of this, there's usually, again, as Dr. Brown was saying, a discussion that reviews the literature. Here it gives you the references, but that discussion hasn't been completed yet. So the discussion is under development. So that will be coming. The Yale consensus guidelines look very similar. They're a little bit more complete. But they do, it's a similar pathway for that. So again, this is available to anybody to go and look, to share them with your primary care doctor, with your medical oncologist, if that's who you're seeing, whoever, gynecologic oncologist, they're there for you. The Yale consensus guidelines are a little bit, they're published in journals, but they're still available to the public. So if you just Google them, you will find them. Dr. Brown, anything that you'd like to see added to the guidelines going forward? Well, besides a discussion.
I think the one thing is we now really know appendix cancer is not colon cancer, and we used to treat appendix as just another extension of the colon, but we're learning more and more that it's biologically distinct. And I think I'm sorry, there's a fire alarm going off right now.
We can't hear. Can't.
I think the one thing is if you look at the guidelines, or if you look at especially like NCCN, there's a very distinct point saying that these are all 2A recommendations, meaning they're really not based off of the highest level evidence and data that we can. And I think that's something that we really need to work on, if we can, to focus to try and get higher level evidence for appendix cancer.
Yeah.
And so
Yeah,
that's
and it's not because they're not using that evidence, it's because that evidence doesn't exist at that level. Again, because it's such a rare disease and it's hard to do the gold standard randomized control trial and that sort of thing. So yeah, I agree. Yeah. But that's exactly, the purpose of ACPMP is to, try to help support that research, to develop that data, to gather the collective wisdom of the patients and their families. They have their patient registry where patients can go and put their own information in, and just kind of get everybody working on this together so that we can come up with that evidence that you said we need so desperately. So yeah, yeah. Dr. Cohen, what do you think? So, patients and their families, should they use these guidelines to advocate for themselves? And if so, how? Oh, I think you're muted. Sorry.
I'm unmuted now.
You are, yes.
Okay, great. Me and technology. Okay. So yeah, I mean, I absolutely think that patients and their families should be using these to advocate for themselves. As I said before, depending on where patients are seeking care, some patients may be going to see physicians who are not very familiar with appendix cancer, may not know about the NCCN guidelines because they're brand new. The issue I think with the Chicago and the Yale consensus guidelines is people who are deep into the field of appendix neoplasms and peritoneal surface neoplasms know these and read these, and they were published in journals that we read, right? But they were not published widely in journals necessarily, although in some journals that medical oncologists who have a broad practice, or surgeons who have a broad practice, may be reading. And so they may not be aware of these, and they're not promoted in the same way and given the same recognition as the NCCN. So that's why it's such a big step forward, actually, that the NCCN has these guidelines. It's truly amazing. So I do think that patients and their families should be advocating for themselves by reading the guidelines, by showing them to their treating physicians, by asking the question of saying, okay, if this is me, where am I on this algorithm, so to speak? Clearly, none of this is cookie cutter medicine. I mean, this is what Dr. Brown was saying. It's not like just go down the pathway and you forget who the patient is in front of you. I mean, it's all about the patient in front of you. But to be able to at least have a discussion, a very informed discussion with your doctor about, okay, this is where I stand now that we have these guidelines. What do you think we should be doing? And if and that may hopefully improve patients' access to additional treatments, and can also help their physicians guiding their treatment if they may not be so familiar with appendix neoplasms.
Yeah. Dr. Brown, anything else to add to that?
No, I think Noah said it really well. It's just it's to kind of guide and frame your disease course and to get a basic understanding of what can be done, what pathways exist, with the understanding that you might not fit into any particular pathway.
Yeah, but I agree with you both, and I think you absolutely have to be looking at the person in front of you, their exact situation, not just the guideline, but for the patients and their families who are, just getting started. It is a way of getting you hopefully to someone who has seen a lot of people in that situation and knows the guidelines, knows sort of like if there was a standard way of treating, like what that would be, but also knows when the situation is not standard, right? How to pivot, what the other alternatives are, what makes the most sense, really be able to translate those guidelines into really valid treatment options. And so, I know that's also another huge part of the ACPMP's mission is to help people advocate for themselves, to get to the experts, right? To get to the high volume institutions that do HIPAC. Those are the places that are going to have the medical oncologists and the pathologists and the radiologists who know most about appendix cancers and tumors, know how to treat the whole spectrum of the disease and really help take care of the patient. So I think this is great. I think this is a place, if you are working with a general surgeon who, says, wow, I saw one of these when I was a resident, let them know, advocate for yourself. This is really important, and say, well, hey, have you looked at the NCCN guidelines about like what to do? Do I really need to have my right colon taken out? Or, should I be seen at a high volume peritoneal surface malignancy center? Right. I think this is a real opportunity for that to happen. You guys, any thoughts, like does this help us or hurt us in regards to insurance companies? What do you think?
I've seen both.
Yeah.
To be honest, I've seen both, especially when before the appendix cancer guidelines came out, in light of the PRODIGE 7 trial, which was most focused on colorectal patients, and they compared people with cytoreduction alone, so only getting their tumor removed, to tumor removal plus HIPAC. I've had some insurance companies in light of that study deny HIPAC for colon cancer. Even though we use a different drug, it's a different regimen. That study is ongoing of a lot of what we use now in the United States. So I think it's still a work in progress to see what will happen with appendix cancer. I still advocate, I still do HIPAC for colon cancer. I do it for appendix cancer. And so I do also carefully document what I do. Like, I will cite the peritoneal surface consortium guidelines in my note that the insurance company would look at to say this is recommended by this group. And I really haven't had a whole lot of a hard time with appendix cancer. It's been more with colon cancer.
Yeah.
I think it's my experience has also been quite mixed. I think that the PRODIGE 7 trial for some insurance companies made it very challenging to do a HIPAC for patients with colon cancer specifically, and having to get into a lot of discussions with the insurance carriers about coverage. And I think that it's helpful. I mean, just because things are in the NCCN guidelines does not mandate insurance coverage, or like center for like CMS coverage for things. Usually only the highest level of data, so level 1 evidence. That's when we have a randomized controlled trial where half the patients get one treatment, half the patients get another treatment. We have a very clear answer from that. Insurance companies will always, essentially, or almost always, cover that. Anything that's sort of less than that, a lot of it's based on the carrier, I think. And it's not like just because it ends up in a guideline, it has to be covered. Most of the time it does get covered. And that's also one of the interesting things specifically about NCCN guidelines, is that they're very aware that the things they put in the guidelines are typically covered by insurance most of the time. And so they are careful with what they put in because they know that, carriers have to usually cover it. They're so new. I'm not sure what the effect is right now from NCCN.
Yeah, yeah. Well, I agree with you. I've had the similar experience, particularly in colon, but I've had less trouble with getting HIPEC for appendix ever approved. But I would just say to anybody who's listening, if you do run into that situation, I think we're in a position now where these guidelines, especially with NCCN, will actually help. So, if you run into trouble with your insurance company saying, usually they say it's experimental. I think we're well beyond that now. I hope nobody's still running into that problem. If it's just not covered by your insurance company, that can be another battle, like Dr. Cohen was alluding to. But the other thing too is if you're in an area where there aren't high volume specialists within your network, there's a way to get around that if you need to be seen by a high volume specialist through what's called a gap exception, and you just need to ask your, whoever you want to see to request that for you, and hopefully you can then get to see the provider that you want to see. That's a specialist in the area, and I think these guidelines will also support that, right? Like that. This is a rare disease. It is complicated to manage sometimes, and it really needs to be taken care of by somebody who is an expert and specialist in this area. So something else, another way to kind of leverage the guidelines. Great. Dr. Cohen, are you good, or do you have to go?
Uh, in about a minute, I do have to go. I'm sorry.
All right. Well, any parting thoughts, and then we'll probably go to some of the questions.
For me, I think Dr. Lambert, you mentioned before that there was a patient advocate who was part of the Yale guidelines. There's actually also a patient advocate in the NCCN guidelines. So for patients and their families, or ACPMP or whomever else, there are ways that patients and advocacy groups can be involved in shaping guidelines and at least having a seat at the table.
Yeah, great. Yeah, absolutely. And I encourage people to seek out those opportunities. I'm sure through ACPMP, they could help people who want to get involved and partake in being a part of these guidelines and see how or even just seeing the process. It really is quite something. I know Deborah Shelton was involved with the Yale Consensus Consortium guideline, the process of developing those. So it's an eye-opening experience, but yeah, great. Well, so we had some pre-submitted questions. Thank you, Dr. Cohen. Good luck.
Thank you. Thanks, everybody.
But Dr. Brown and I will kind of pick away at some of these questions, and then we'll open it up to the live questions that may be coming in. Dr. Brown, we received some questions about like surveillance and follow-up. Somebody was asking is the best surveillance protocol for a low-grade mucinous neoplasm, a T4A, and also how many people diagnosed with a low-grade mucinous neoplasm, a T4A, after laparoscopic appendix removal have a recurrence of the appendix cancer elsewhere in their body. Your thoughts on that?
So there are guidelines to follow. Now in the NCCN, they lay out some guidelines. They talk about scans about every 6 months for 2 years, and then yearly for a couple years afterwards, and then scans every 2 years up to 10 years. Because even though it was removed, sometimes people can have this show up and it can show up again much later. There's some guidelines, if you look at, that say that if you don't have free mucin throughout the belly, you don't have any signs of extraperitoneal or spread throughout the abdominal cavity, you get a complete resection, you could actually forego surveillance. So it's really a mixed bag on these. Dr. Lambert, I'd like to hear your thoughts on that too.
Yeah, yeah. So You know what again, it really depends on the histology. So obviously in this case, it's a low-grade mucinous neoplasm. In that case, and it's a PT4, so there's a perforation somewhere. The way I approach these is when I'm doing the laparoscopy or if I get the report, I look to see if there's any mucin anywhere else in the abdomen, if there's any development of that yet. If there was some mucin reported at the time of surgery and the surgeon said they got it all out, but it was confined to the right lower quadrant, and I just survey those patients. I don't recommend any additional surgery at that time and just keep a close eye on them. If there's mucin that has gotten out of the right lower part of the abdomen, then I start talking about cytoreduction and HIPEC and suggest that at some point the person is probably going to need it, but depending on the actual circumstances, if it's just a very low volume, maybe a little bit up around the liver or something in the pelvis, that's something that you can watch, right? This tends to be a very indolent process. If you're keeping a close eye on it, what I always tell people is you're not going to miss an opportunity to treat somebody for cure in that situation with that disease if you're surveilling for a while, and as soon as you see that it's starting to change, then you can talk about going ahead with surgery at that time. So that's usually how I approach it. My surveillance is usually 6 months every 6 months for the first 2 years, along with tumor markers, 3 tumor markers, CEA, CA 19-9, and CA 125, and then yearly after that out to 5 years, and then every other year after that out to 10 years. And at that point, we're not really sure what to do. Like I've asked other people, I'm sure you've thought about this too, Dr. Brown, that, like at 10 years, the likelihood of it coming back is extremely low. It's not zero, but it's low enough that I think it's safe to stop surveilling every other year. What are your thoughts on your timing of surveillance?
I follow basically the same thing that you do. I think that's a pretty good pathway. What are your thoughts on CT versus MRI?
Great question. So, so I think both are good studies, and each one has its pluses and minuses, right? Its pros and cons. I think the obvious benefit of MRI is the lack of radiation, right? So if you have a young person who's going to be followed for a long period of time, a lot of scans, and is eager to avoid as much radiation as possible, I think MRI is a very good option. The caveat to that is you need a MRI radiologist, like a dedicated abdominal MRI radiologist who's interested in reading these scans and is willing to do the specific protocol that you need, right? With the rectal contrast, the oral contrast, timing it just right so that you're getting the bowel opacified and all that sort of stuff. And then the MRI takes time, right? So somebody has to be there for a while. And then the challenge, I don't know about for you, but I am not great at reading MRIs, right? Like I do okay, but not for subtle findings. It really takes an extra lot of training to read an MRI well. But as a surgeon, we get really good at reading CAT scans. And so for a surgeon, putting on the surgeon hat, I find it a lot easier to read a CAT scan. It gives me all the information that I need to make a decision about whether to go to the operating room or not. It's faster for the person that's getting it. And the radiologists are also very good at reading CAT scans too. Like you don't need a specific dedicated MRI person. So, but the downside is the radiation. So, yeah.
Yeah. There's some interesting data presented at the Peritoneal Surface Oncology International meeting about MRI, and what they were finding is properly timed MRIs can be more sensitive, so they can find disease earlier. So what I typically do I feel like if it's a higher risk patient, if they're younger and I want to avoid the radiation, try and get that MRI for them. But then going to surgical planning, I'm much more comfortable looking at CTs, and I think it really gives you good anatomic definition if you get thinner cuts. So I would advocate for a CT scan.
Yeah, great. Let me see. There looks like there's some question. There's somebody posted a very interesting question about And I know you've come across this too, in women who, present with a pelvic mass, a bilateral ovarian masses, and obviously the first thought is this is a GYN malignancy or an ovarian cancer, because that is a lot more common than appendix cancer. But then they get taken to the operating room, and obviously, and then people find out that it's actually an appendix cancer. So the person that posted the question is asking, once we get the diagnosis, the real diagnosis of an appendix cancer versus an ovarian cancer, does that then get counted as an appendix cancer in terms of the statistics? And is appendix cancer way more common than we think it is, but we've just been misdiagnosing it all along? What are your thoughts on that?
I believe recently it should all be classified as appendix cancer because it's really the histological finding that's being classified. Um, we see this all the time. It's a very common thing across the United States because somebody sees a pelvic mass or you have ovaries that have tumor or mucin in them, and you get sent to a GYN doctor. They think when they hear footsteps, they think horses and not zebras. So they think common things are common, and that's kind of what they're going into this for. Um, we get called to the operating room quite a bit to go in there when this situation occurs, and it's kind of just to tell them get tissue, understand what you're dealing with, and stop because you want to be able to treat the disease appropriate from there, and not do something that could potentially steer you down the wrong path. So I believe we're not misrepresenting the incidence of appendix cancer with this situation. Um, but what are your thoughts, Dr.
Yeah,
Lawrence?
I mean, I think this is it's an interesting question, and there's a lot of different aspects to it, right? Like, so, I do think appendix cancers are still category they're still considered a rare cancer, but there is no question that there's more than I think what is being reported, right? I think the statistics are behind what the truth is, and we had a report that came out last year showing an increasing incidence in younger people. But there's definitely literature to show that the true incidence of appendix cancers and tumors is increasing. And I do think that once somebody is correctly diagnosed, and that gets counted in the appendix bucket, like you were saying, right? But the other side of this question, I think is really important is helping educate people to recognize an appendix cancer instead of an ovarian cancer, right? And there are some things that I think are kind of low hanging fruit, if you will, that can help. So in most women that get ovarian cancer, it's usually just one ovary that's enlarged when they have ovarian cancer. That's one thing. They often do present with fluid in the abdomen or ascites, but that can look very different than mucin on a CT scan. So you got to get a sense of that. The appendix, like if there's preoperative imaging, the appendix should be looked at very carefully because you can often pick up that the appendix doesn't look normal before you go in to do an ovarian surgery or cancer surgery. The other thing is tumor markers. And if the tumor markers suggest that this may be coming from the intestine or the appendix, the tumor marker that's going to show that the most is the CEA. The CA 125 is what we classically associate with ovarian cancer, and it is a very good marker for that. But it can also be elevated in any other cancer that's growing in the abdominal cavity. But when you have a combination of a high CA 125 and a high CEA and or CA 19.9, now you need to be thinking, could this be coming from someplace other than the ovary? And yeah, I know you've had this experience before where you meet a patient who's been taken to the OR, had a hysterectomy, oophorectomy, omentectomy, like this surgery, even though the CEA was elevated, way elevated before the surgery, only to find out at the time of surgery that the appendix was abnormal. And that's the other part of the education that I would love to be able to get out there is that if you get into the surgery and you notice that the appendix is abnormal, to not do all the other things that you would do for ovarian cancer, right? Like stop. And this is what we try to teach, as you know, teach our residents, teach other surgeons, is just if it looks like the appendix is abnormal, take the appendix out if it's easy, or do what you have to do to get the right diagnosis and get the person to the place that they need to be to get the best care right from the start. That, you know, I don't think we can say that enough. And I know we say it all the time in our webinars and with the ACPMP Research Foundation and everything that they do. So for those of you who are listening, we're trying to get the word out. And we hope that, you know, through like ACPMP, we'll advocate so that we can avoid this in, you know, in as many people as possible. So they just get the diagnosis right up front, get to the best care as quickly as possible. So let's see, a couple more questions coming in. Let's see. So here's a question. Would you recommend cytoreduction in HIPEC surgery if appendix cancer has gone into the liver or lymph nodes outside the peritoneal cavity? What are your thoughts about, like, how do you think about that?
I think what is the disease biology that you're really treating with? Like, what does the tumor look like under the microscope? Is it presenting at the same time? Are they presenting at different times? How long has the disease course been going on? Have you gotten chemotherapy? Have you not gotten chemotherapy? And what was your response to that? So I think all those factors go into play to making that sort of a decision. And kind of my thoughts, how I was trained, the people that I grew up with, is you can do it, but be careful. And so it's all about selecting the right person that could benefit from it. Because what I see as a failure on my end is to take someone through a very large operation, get a scan a couple months later, and the tumor is somewhere else.
Yeah,
So I
yeah.
think you really need to prove the biology of the tumor, that it's behaving, it's responding to chemo, and that you can get a complete resection. And
Yeah.
I'd be very hesitant to do a very major liver operation that on its own is risky and dangerous, and combine that with a bunch of other operations to clear a tumor out. So I think a lot goes into play. Have I done it? Yes. Have people done well afterwards? Yes. But it's really timing it out and being very, very thoughtful about it.
Very selective, exactly. You know, I think one thing, you know, that we hear from people is, I mean, I think anybody who's got cancer, right? I mean, the first thing you want is you want it removed, right? Like that seems to be the most obvious thing. Just get it out. This is going to be the most helpful. But like you said, you know, as much as we love to operate, and that's, you know, what we want to do more than anything, we also don't want to put somebody through a huge operation that ultimately is not going to be helpful. And so I know it can seem like we're delaying or stalling or whatever. But when we're recommending that somebody get systemic therapy, chemotherapy before a surgery, it's exactly what Dr. Brown was alluding to, is that we want to make sure that when we do this big surgery, that it's going to be helpful. And, you know, as probably everybody on this call knows, the cytoreduction in HIPEC just treats the abdominal cavity. So if there's cancer outside of the abdominal cavity or inside the liver, we really need to make sure that we have treatment that's going to control that disease and hopefully get us to a point where we can remove it surgically as well. But this is where it really comes down to why you need to be at a high volume center with surgeons who have done a lot of this and are thoughtful, and they have partners that can help each other think about these things and look at it from all these different perspectives. And you have medical oncologists who are familiar with the disease, and radiologists who can read the films really well, and pathologists who can really nail the pathology. I mean, there's a number of questions in here about like Hammond and Lamon, and we haven't even gotten into the pathology of appendix cancers and tumors, but that's a whole nother, you know, kettle of fish, and very challenging. So you want experts on every front when dealing with these kinds of tumors. So and so speaking of histology, right? So there's a relatively new entity called Hammond, and I see that coming up in the list here. Dr. Brown, your thoughts on where Hammond fits into the schema of things. It's a relatively new diagnosis or histology, I should say, and it's been challenging. What are your thoughts?
Yeah, I think it's extraordinarily challenging for the pathologist, the person that's actually looking at the slides. So to call something a true cancer or an adenocarcinoma, what they need to see is invasion. They need to see those tumor cells start invading through kind of like the sublayers of the walls of the organ or the appendix in this case. When we talk about a Hammond, Hammond's very similar to what I think of as a lamin. It's not invading through the layers, it's more pushing the layers. And it can be very, very challenging for the pathologist to differentiate between a Hammond or a high-grade tumor and an adenocarcinoma. And to really call it an adenocarcinoma for, say, Hammond, they really need to determine, is it pushing or is it invading? And the difference really between a Hammond and a lamin, or low grade and high grade, is really what it looks like under the microscope. Does it look more well-behaving, more normal, or does it look more abnormal and more high grade? So I think it's a very challenging entity. There was a big discussion about that at the SOGI meeting about Hammond, and they're talking about how challenging is it, and there was a big talk on, should we call Hammonds actually just cancer? Are they actually just adenocarcinoma, or are we really capturing the full picture of what's going on there? But I think it's a big challenge on the pathologist's part to help really do that. And I think that's where it goes into really having a pathologist and trust, who sees more than one of these a year, to be able to make that determination.
And I would, strongly encourage somebody, if you're getting a diagnosis at your institution, and it's a Hammond and not a Lamin, and your surgeon's kind of like, I don't think it's a ham. Like, if there's any sort of discussion, request a second opinion on the pathology. Your institution should be able to send your pathology, your slides, to an expert in appendiceal pathology if you don't have one at your institution, and get that read. It can have a huge impact, because if you look at the literature, like Dr. Brown said, these Hammonds are really in this gray zone. They technically don't reach the definition of a cancer, a true invasive adenocarcinoma, but they definitely are more aggressive. That's the word we use, than lamins. So they're more likely to come back. And if they come back, they're less likely to be treated for cure as well as a lamin. So it really makes a difference in how you're going to approach treating somebody afterwards, if it's lamin versus Hammond, and the prognosis and what to expect. So it's worth getting a second opinion if you're at an institution where your pathologist is not like a high volume expert in appendiceal cancer. There's another question here on genetic connections in appendiceal cancer. What are your thoughts on that, Dr. Brown?
I think we have a lot of work to do.
Yeah, I would agree with that. I would agree with that.
I think that's kind of the biggest takeaway that I get
Yeah.
from doing this. We have a lot of work to do. You mentioned that study that came out
Mhm.
very recently that looks at the uptick of appendix cancer, especially in younger generations. So younger generations, we're seeing a higher incidence of appendix cancer. And I think the one thing is we really don't know why that's happening.
Mhm.
Because it
Right. Yeah.
environmental factors, is it
Yeah.
genetic factors? We're really not sure. Is it a combination of both? I'm often asked by people, should I get my appendix taken out? Should I just prophylactically get an appendectomy? We really don't have evidence or data to do that. And there's really no such thing as a minor operation. So to go and prophylactically take out the appendix so this doesn't happen, we don't really have that data yet to do that.
Mhm.
And so I think appendix cancer still is rare. It's still a rare tumor, and I wouldn't recommend people just getting their appendix taken out.
Yeah, yeah. Yeah, a lot of people ask me that. Why don't we just take out people's appendixes, right? And we'd have to take out a lot of appendixes to avoid one appendiceal cancer, which obviously would be worth it, but for that person, but at the end of the day, insurance companies aren't going to approve just having your appendix taken out to avoid a cancer that is considered very rare. But for the research part, so there actually is a study at Vanderbilt that is looking for people who get diagnosed with appendix cancer to join and to just submit their data, and there's answer questions on a survey. It's the GAP study. Dr. Halawaja is the primary investigator on it. I'm sure you could find information on it through ACPMP, but feel free to, you can Google it, find out more information, and basically it's a patient's putting in their data into the survey, and they're looking at all these different connections to try to figure out if there's something, like Dr. Brown said, in the environment, in our diets, genetically, that's driving appendiceal cancer. I personally have only had two patients that I know of who had like a first degree relative who also had appendiceal cancer, which is actually kind of a lot for a rare cancer, but it's still not enough for us to say, if you have appendix cancer, then your children should have their appendix taken out. Their risk of getting appendix cancer is about the same as what yours was, and still quite very low, obviously. So let's see.
There's a question here I'd like to get
Yeah.
have you speak about the role of diagnostic laparoscopy.
Oh, great. Mhm.
I think that's a really interesting question, and you want to kind of address that, like why would somebody recommend a diagnostic laparoscopy in the
Absolutely, yeah. So it kind of comes back to what we were talking about before, wanting to avoid a big surgery in someone if we can. And so we use it for in a couple of ways. Particularly, I use it in a couple of ways, particularly with people who have the high grade tumors. So one of the things that can be very challenging about those tumors, specifically like the signet ring cell or a poorly differentiated adenocarcinoma, is that they tend to grow like a coat of paint on the sides of the abdominal cavity or on the bowel. So they're not making these discrete tumor nodules that show up really nicely on a CT scan or MRI, and you actually can't see them on imaging at all. And so the CT scan or the MRI will most often really underestimate the amount of cancer that's present in the abdominal cavity. So by doing a diagnostic laparoscopy, we can put a camera in, look around, really assess the entire abdominal cavity, specifically though, the small intestine and the sheet of fat that contains its blood supply called the mesentery. Because if those are heavily involved with cancer, then it's unlikely that a surgeon is going to be able to get a complete enough tumor removal where the heated chemotherapy would be helpful. So by doing this, you've now avoided making a big incision, on the abdomen to get in and then find out, this is unfortunate, but we're not going to be able to do what we hope to do today. You start out, the nice thing about the laparoscopy is you can do it with just a couple of tiny incisions. A person doesn't have to stop their chemotherapy to get it. You go home the same day. It takes about an hour. You can get pictures so that the patient and their families can see what's going on in the abdominal cavity. And then they have a better sense of what the cancer looks like and what we're talking about when we talk to them about this. And we can figure out if it makes sense to proceed with cytoreduction and HIPEC at that time, or if somebody should continue with intravenous chemotherapy, and or if that chemotherapy should be changed, right? Because we can tell if the tumor is responding or not, especially when we can't see it very well on scans. So yeah. How about you?
I use it the same way. So the one thing that I have is can we do the operation that you would need?
Mhm.
And I don't like people to be surprised. Is that I like to be able to have an informed discussion with somebody of this is the extent of what's going to have to happen in order for you to have an optimal cancer surgery. So I think it allows me to assess, can it be done? Should it be done? And then have a person know what needs to be done to them and not have more of a surprise when they wake up because, like you said, a lot of these tumors can form sheets instead of discrete balls, and so your scans can underestimate it. I also think it's helpful if there's a question of a diagnosis. So you're getting your surveillance done, your tumor markers are going up, you're getting the scans, and nothing is seen. I think that's a good role of a diagnostic laparoscopy is to help try and make a diagnosis. Is something actually there that we just can't see?
Mhm.
Um, there's a couple questions on signet ring cells.
Yeah.
I see that. It seems to be a thread. Do
Yeah, yeah. I mean, and signet ring cells are tough, as you know. For the reason that I just mentioned before, that they tend to be hard to see on imaging. They grow like a plaque. They are considered a more aggressive type of cancer. They are more likely to spread to the lymph nodes, that guard the appendix. I think if there is any silver lining for signet ring cell, they tend to respond to chemotherapy, at least initially, right? So the way chemotherapy works in general is rapidly dividing cells take up the chemotherapy into their DNA, and it's like throwing a monkey wrench into the works there. And so, because the signet ring cells tend to divide more rapidly, they are more responsive to the intravenous chemotherapy than, say, a lamin or a low-grade appendix adenocarcinoma, where the cells are just kind of poking along, dividing very slowly. So there's less opportunity for them to take up the chemotherapy into their DNA. And then, there are a lot of people who, probably don't think that there's a role for cytoreduction and HIPEC with signet ring cell. But that has not been my experience or my practice. But I will approach this with recommending that we start with the intravenous chemotherapy first for the reasons that Dr. Brown talked about, testing the biology of the tumor, making sure it's responding to chemotherapy. And if it is, the benefits of that are: one, we know that it responds to chemotherapy; two, it's going to do some of the cytoreduction for us so that when we get in there to do the surgery, we have less surgery to do and it's likely to be more successful. So that, those are the reasons for starting somebody on intravenous chemotherapy first, and then assessing for if you can get a complete tumor removal and do the HIPEC. I will definitely offer that. And now we're starting to have another option for in a situation where if we're not quite able to do and not get the tumor out completely to do the HIPEC, we can offer something called PIPAC. And I'm gonna let Dr. Brown talk about that a little bit. So Dr. Brown, where does PIPAC fit into your treatment recommendations?
Yeah, so PIPAC, for people who don't know, is laparoscopic administration of chemotherapy as an aerosol. So typically, in a majority of cases, HIPEC is delivered at the time of tumor removal. So people get a cytoreductive surgery with or without the HIPEC, so the liquid chemo. PIPAC has been being done in Europe for about the last 10 to 15 years, has really come to the United States within the last 5 years or so. And it's an alternative method to deliver chemotherapy in the abdomen. Really good benefits from PIPAC is people can stay on their systemic chemotherapy. They can keep getting IV chemo, and you can drop one of the IV chemo rounds, and instead of that, you can do a PIPAC operation. PIPAC, I really see it fitting into people that are either anatomically or biologically unresectable, meaning if you can't take all the tumor out, if you're progressing on chemotherapy, if you've been through multiple lines of trying to use this really as a salvage operation. We still have a ways to go to see where this could or would fit in our guidelines, and whichever ones you're talking about, NCCN, Yale, to really find out where this goes. So it's still an ongoing project and something that peritoneal surface surgeons across the world are really working on, is to try and figure out where this fits. But right now, what I see this is a potential alternative to try and help salvage a situation. And with that, PIPAC does not replace systemic chemotherapy because the PIPAC really only treats that disease in the peritoneum. It doesn't treat disease elsewhere. So if there's disease in the liver, the lungs, PIPAC will not treat that. It's really only localized disease. So I think there's still some work to go, but I see it as kind of an alternative method to deliver chemotherapy into the abdomen.
Yeah, right, yeah, exactly. And as Dr. Brown mentioned, it's something that's evolving. I think there's a lot of data now that it is safe. We actually started doing it here at NYU just recently, thanks to Dr. Brown's efforts to bring it here. And we are offering it in very selected situations, like he said. And we're hoping to join a clinical trial that's hopefully we'll be opening up soon at the City of Hope to be able to offer that to people in the New York area to have that as another option. But we are offering it now, and again, in very selected situations, we want to be very thoughtful about it as well. So, a couple of questions are coming up about like repeat hypex and cytoreduction and additional surgeries. What are your thoughts on that, Dr. Brown?
I think number one is what disease are you treating? Is it a Lamin sort of a situation? It's appendix cancer situation. For the Lamins, I've done a bunch of repeat hypex on them. I think it's just when are you going to pull the trigger to do it and to be thoughtful about it. It's safe to do repeat hypex on people. As a surgeon, it can be a little bit more challenging. The more scar tissue you get, the more adhesions. It can take a little bit longer of a time. So when are you going to go in to do that? I think is the big question. For appendix cancer, so the invasive cancers, I think it's again being thoughtful about doing it. What was the time frame between first surgery, second surgery? Is there disease elsewhere? Have you gotten chemotherapy? If so, what has been your response to chemotherapy? So I think what we know, there's studies looking at this, is that it's safe to do, it can be effective to do, and to really be thoughtful about doing it.
Yeah. I think I hope like just sort of as we're kind of thinking out loud, like how we would think, uh, how we would think about these situations in real time, right? Is that it's you have to look at the whole picture, right? Like just like you said, starting with what type of histology is the tumor, what treatments has the person had up till this point, how did they respond to chemo? How did the cancer respond to chemotherapy if they got chemotherapy? What does the surgery look like that you would have to do to get a complete cytoreduction? It's just taking it's the whole package, and it takes a lot of thought and personalization, right? We have guidelines, but there's no sort of textbook way to treat this like there is. Every single person is unique, and every situation is unique still at this point. So again, just really advocating for people to get uh, to the place where they need to be to get the care that they need. Yeah. So let's see what else. I think we still have a few more minutes. Go ahead. Yeah.
Questions about appendicitis.
Yeah. I saw that. That's a great question too.
Those are interesting questions.
Yeah.
What are your thoughts? Antibiotics, surgical removal.
Yeah. So, so obviously, I think there's definitely data to show that older people, and by older I mean over 40, people over 40 who present with what we call complex appendicitis, meaning the appendix is already ruptured, or there's a lot of swelling and inflammation around it, in the area around it, and where it would be very challenging to try to get it out with surgery at that moment. There's data that the typical practice is to put somebody on antibiotics, let the appendix cool down. And for a while, there was a move to actually not remove the appendix at all. And the reason for that was because the risk of getting recurrent appendicitis was only about 16%. And so rather than going back on everybody and taking out their appendix, to avoid, a recurrent appendicitis in 16 out of 100, out of 100 people, when you could just take out the appendix if they had appendicitis again. So there was a move towards that. But more recently, there's been a number of studies that have really, in my opinion, demonstrated that people over 40 who have complex appendicitis have a significant risk of having a tumor in their appendix that's related to what's going on. And they should have their appendix removed, whether it's at that moment or as an interval appendectomy, it should be removed. As a matter of fact, there was a randomized control trial looking at following people with complex appendicitis with MRIs. And there was such a high incidence of tumors found on the MRI that they actually ended the study early because it was that significant. And the recommendation was made to just do an interval appendectomy. So that's the way I think about it. And again, this has been confirmed in a number of trials, small trials, retrospective, but also larger trials as well, prospective trials. That's those are my thoughts on that. And yours?
I think the one thing too is part of the thought process was also like, oh, people can get a colonoscopy. You can get a
Yeah.
colonoscopy to take a look. But
Mhm.
the one thing is a colonoscopy doesn't look inside the appendix. It sees the opening or the orifice of where the appendix connects to the colon, but you actually don't look inside. So you really don't know what's going on. And so I'm a big advocate. If there's suspicion, you should do an interval appendectomy and take it out. Um,
Yeah, I agree. Yeah. Let's see. Did I ask a surveillance for? Let's see. I guess there's a number of questions also related to uh, um, goblet cell cancer, right? So, what are your kind of general thoughts on that? Where does it fall in the spectrum of these cancers? Do you treat it like as a higher grade tumor, a lower grade tumor? Do you do cytoreduction and HIPEC for them? What are your thoughts on that?
Again, it depends. So I think the thing is I think of a goblet cell cancer as almost like a collision between two separate type of tumors. It's kind of a mix of an adenocarcinoma that you can get from the appendix and a neuroendocrine tumor, also known as like a carcinoid tumor. So it could be similar to a mix of those. And so there are classification systems that we use. The older one is the Tang classification, and that's Tang A, B, or C. A being a more well-differentiated, so a better acting tumor, a Tang C as a more poorly differentiated tumor, and a Tang B where it kind of hangs out in the middle. And so when I think of a Tang A, it's more of the neuroendocrine type tumor, more indolent, more slow growing, and a Tang C is a more aggressive tumor. They've kind of started to reclassify this. There's also the WHO or the WHO classification of this, the World Health Organization, where it's 1, 2, and 3, and it kind of follows the same pattern where A is 1, B is 2, C is 3. And how I look at it is people with more Tang A or WHO 1, those people, I'm a little bit more aggressive to take those people to the operating room and do cytoreductive surgery with or without with HIPEC if they have peritoneal disease. I also I do a right colon on these people as well. Where at Tang C, I'm a little more cautious.
Mhm.
Is that these tumors can spread elsewhere outside the peritoneum, and so what I generally advocate, especially for the Tang C, is those patients start with chemo.
Mhm.
Because I think the one thing to keep in mind is one of the number one reasons why people don't respond to chemotherapy is they don't get it, is that it never actually goes into your veins.
Yeah,
So
yeah.
if you're going to go through a potentially could be a very major operation with 2 months of recovery, that's going to delay the start of your chemotherapy. So it's really, again, being thoughtful of the actual histology and the disease that you're dealing with.
Mhm. Yeah. Yeah, I agree. And I manage them very similar to you. I kind of talk about them as a rare subset of a rare cancer. And I see them kind of somewhere in the middle between like a moderately differentiated adenocarcinoma and a poorly differentiated adenocarcinoma. And like you mentioned, it's almost like there's two different tumor types, the neuroendocrine and then the adenocarcinoma. And the treatment is really dictated by the histology of the adenocarcinoma. So like you, I usually do recommend a right hemicolectomy, if especially if the adenocarcinoma part is moderately differentiated or higher, grade 2 or higher, because the incidence of lymph nodes metastases is higher with that. And then again, like you, just thoughtfully use cytoreduction and HIPEC as part of a multimodal treatment plan, including systemic chemotherapy for most people as well. So, yeah, great. Let's see. Um, so, I know in other times people have asked about BromeAC. And so I'm proud to say that we we actually had an opportunity to use some BromeAC here. And again, this is something that we're doing in a very selected way. And people have been asking about it for a long time. Dr. Brown, you want to share your thoughts on BromeAC and its role in managing pseudomyxoma?
Yeah. So, what BromeAC is, it's really a compound of two different drugs. Bromelain, which is well known for being derived from a pineapple, so pineapple stems, and then acetylcysteine. Acetylcysteine is a drug that we've been using for a long time. A lot of times is a mucolytic in the lungs to break up. A lot of times in kids with cystic fibrosis, they get these big mucin plugs in the lungs that can help break those up. So it's a compound of these two different drugs to act as a mucolytic. Because one of the issues, especially with PMP or pseudomyxoma peritoni, where you have this really thick mucin in the abdomen, is that sometimes it's not resectable surgically and you can't take it out. So this is a way to help treat those tumors. And the way you do it is you place a catheter, or the interventional radiologists are able to put a tube into that mucin, and then you can inject this drug. And the thought is that this will help almost dissolve and make a very thick liquid into something that can be pulled out of a tube. And so I think it's a palliative option that's out there. We're still looking to bring this to clinical trial in the United States. So it's done under compassionate use. So you have to go through the FDA, or we go through the FDA to get specific and special permission to do it. But I think it has a role, and I'm really hoping and trying to advocate that we can get the company the kind of the support they need to really help bring this to clinical trial in the United States, because I think a lot of patients could benefit from it.
Absolutely. Yeah, exactly. And we're hoping we can get there too. I know we've been hearing about it for a number of years, and a lot of people have asked about it, and I think it will bring hope to a lot of people. So I just want to acknowledge that, there are a lot of questions in the chat that are kind of very specific to individual circumstances. And I hope you can appreciate from just the conversation that Dr. Brown and I have been having, that it can be very difficult to answer specific questions to an individual circumstance without having the time to look over the imaging and review the history, and more importantly, have a chance to talk to you directly and get hear the story from you and get a sense of where you are on this journey with appendix cancer or pseudomyxoma. So we apologize if it seems like we're kind of avoiding answering those very specific questions. We would be happy to see anybody in consultation. We are in New York, we're in Long Island. Dr. Brown also sees patients in Manhattan, so we are accessible. We can do virtual visits if somebody is in a state where we have where we're licensed to see you virtually. But so please feel free to reach out to us. We would be happy to definitely see anybody in consultation to give you an opinion. And again, I apologize that we can't get more specific in this forum, without having a chance to really meet you and review all of the data and the images and go over everything with you. The last question here is why isn't BromeAC used in the US? Do you want to answer that, Dr. Brown? We're trying. We're trying.
It's fine. It's currently not FDA approved,
Yeah.
and I think one of the issues behind that is how the drug is formulated and made, and it's a big effort by pharmacy because they have to compound and mix the two drugs separately and then combine it together. And what the FDA really wants is it to be in almost one jar and you just pull it out. And so I know they're actively working on that. And so I think once that's done, they can get it through the FDA to bring it to clinical trial. And it's where support groups are really helpful. And then people advocating that there's folks around the country who could really benefit from this and to use great organizations such as this to really to push and advocate to help get this through so it can get done.
Yeah. Great. Well, I hope this has been helpful. I know that Dr. Brown and I have enjoyed this. We could talk about this all night.
I could talk
We
about this for
really
hours.
could. And we wish we could have answered everybody's questions, like I said, or have a chance to meet all of you in person and offer you our opinions and thoughts and obviously our hopes that everybody gets the absolute best care that they need and deserve. And we'll keep working with the ACPMP Research Foundation to just, get the word out there, educate. Somebody put in the chat about Dr. Radio as a platform to spread the word. Again, ACPMP is doing that through radio programs like this, the symposia that they put on. So we keep supporting them and we keep supporting you. And please, support each other and support ACPMP to help us get a handle on this disease.
Thank you, Dr. Lambert. Well said. And thank you, Dr. Brown, Dr. Lambert, and Dr. Cohen, even though he had to leave early. This was so informative. I think it was amazing that you got to get to so many questions about this. And thank you, everyone who attended tonight. I think everyone pretty stayed throughout the whole webinar. It's fantastic. And yes, please stay up to date on acpmp.org for future webinars. And if you have any questions, feel free to reach out. Thank you guys so much.
You're welcome. Thank you. Thank you for having us. We really appreciate
Yes,
it.
you're welcome. Have a great night, everyone.
Good night.